Okay, good morning, everyone. My name is Christy McAllister. We are so excited you're here on this beautiful Saturday morning. I am a development director for the Cystic Fibrosis Foundation. To get us started, we love this day. It's our CF Virtual Community Education Day, and we love it because it's Washington and Alaska and some of our local people. So we'd love to know where you're joining from. If you want to put in the chat your name, where you're joining from, if you care to, not required, of just your CF connection and maybe how long you've been involved with the CF Foundation. We'd just love to know who all is here with us today. So today, just a couple housekeeping things before I turn it over to Hogan to do our welcome. Yes, this is a meeting, so you do have the ability to be on camera and to mute and unmute yourself. So just while the presenters are speaking, we ask that you do stay on mute so there's not any background noise. And that, again, it's your choice if you want to be on camera or not. As I said, we are recording this presentation. We will post it on YouTube. So if you can't stay for the whole thing, or you know someone that would want to be able to see some of these presentations, we'll have that available on YouTube. We have the Q&A feature. So if you have any questions, you can put that in the Q&A. We also have the chat. I would use that more for comments. If you're like, yes, this resonates with me, or hey, Hogan, great to see you. Kind of fun things in the chat, but any questions that you want answered and addressed, please put in the Q&A. And then if you have any concerns throughout the meeting or any issues, you can direct message me, Christy McAllister, through the chat. There's a little drop down where you can do a direct message, so I can try and help you out that way. When I sent out the link, you guys should have received an event conduct guide. I'll put that link in the chat as well. But just a reminder to be respectful of everyone. And we're also, well, we have wonderful doctors here. We're not asking them for specific advice, medical advice today. So we have a great lineup. You should be seeing the agenda on your screen here. And so we've got 5 different presenters from our local CF care centers. And at the end, we will have a meet and greet. So an optional time for you to stay on, be able to connect with other CF parents, grandparents, and supporters of the CF Foundation. So for most of these speakers, they'll have about 20-ish minutes to talk, and then there will be time for questions directly after they speak. So we've got Dr. Weinstock going first, and then we'll have a Q&A right after him. But some may be a little bit different. I know some of our speakers wanted to be more interactive throughout. So just kind of a general idea. You can do questions for each individual presenter. And then I think that was everything. So I'm going to go ahead and introduce Hogan. She is one of our Great Strides ambassadors, and I won't take away your thunder so you can introduce yourself. But thank you, Hogan, for being here.
Thanks, Christy. Hey, everyone. I'm Hogan Reed. I have cystic fibrosis. I'm 28 years old, and I live in Seattle right now. Yeah, really excited to just say hi to everyone, introduce myself, tell you a little bit about my story with CF. But first, I just wanted to say thanks to all of the doctors, researchers, and the CF staff for taking time out of Saturday to be here to inform us. That's just awesome. And I was just going to say, I feel like events like this are really important to me because if I feel like I understand the studies and I feel like I understand the progress we're making with CF, I feel a lot more in control of my very unpredictable and uncontrollable life with CF. So I'm really excited to learn, feel a little more in control, right? So I only have a few minutes actually, but I'll tell you about my life with CF for just a few. I was diagnosed when I was 3 years old in Portland, Maine, actually, pretty far. And then the first 20 years of my life looked pretty different than my life looks right now. So when I was younger, my life looked a little more like this. I would have IV antibiotics and hospitalizations like at least once or twice a year. I would get used to doing my IVs in like very peculiar places like my high school classroom or my college dorm room, or even like going on walks in the woods with my family with like my portable IV thing. Because it's like, I don't want to miss school. I don't want to miss out on exercise, you know? I had a really gnarly cough that kind of made sleepovers hard when I was younger, just because I didn't want to like keep people up. I had some surgeries, like lung surgeries, sinus surgeries, my fair share of procedures, and I was getting way too used to like seeing my lung function decline year over year. That was my normal. I didn't think it would be any other way, honestly. Something I was really good at, though, was being very present minded. I was like spectacularly good at that, super present, super positive. But the way I was able to do that was kind of just completely blocking out my future. Like I wouldn't think about the future. I wouldn't think about adulthood because what was it going to be like? I have no idea. There was no telling. So I kind of just got used to blocking that out, which isn't great, right? But in 2019, as probably everyone knows, Trikafta was approved. And within 1 month, I started Trikafta and I started my first full-time job as a graphic designer. That's what I do. So it was like a big month, two big milestones at the same time. Yes, I purged all of that mucus up in the first 2 weeks of my job. It was embarrassing, but awesome. So yeah, in the last 5 years since I've been on Trikafta, no hospitalizations, no IVs, my chronic cough is gone. Um, yeah, like my lung function increased. It had completely stabilized. Like you've heard these stories so many times before, but it's been absolutely amazing. Like, don't get me wrong. I still have to deal with some of the CF challenges, right? Like I go on oral antibiotics. I do my lung treatments. My vest is right next to me. But I just feel really good most of the time. And so I started to like actually start allowing myself to like fantasize and daydream about my future. I've like started to realize that about myself over the last few years, and it's like kind of scary, but really, really cool. So what used to be really blurry, unknown, is just like starting to come into focus a little bit. So in 2022, I was living in Maine. That's where I grew up. I've been there my like whole life, pretty much in the East Coast. I made one of those first big like adult decisions for myself to move to Seattle, and uproot and leave my safety net of my family, my care team that I'd known for like my entire life. I wanted a bigger city. I wanted to be near the outdoors, to just like pursue some of my favorite hobbies of like hiking and camping. And because my health was so stable, I was just like able to comfortably do that. I moved here with my boyfriend, so it's been 2.5 years. It's been really, really fun. I'm just starting to get to know my new care team. Shout out to Sid Kapnadak and Christy with the CFF team. Just like moving over to this chapter has been really fun, and also really fun to start to see some new faces in the CF community that are on this call right now. Like I have a lot of networking to do with you guys, but I know you'll see me again because I'll be at the Great Strides Walk. And if you see me, say hi. Yeah, just excited for everything to come. So thanks again to all the speakers. And I'm going to pass it back to Christy after that little rant.
Thank you, Hogan. We are so excited to have you. So thanks for moving to the West Coast, the best coast. Our first doctor speaking today is Dr. Jared Weinstock. He is a pediatric pulmonologist and director of the CF Affiliate Center for both adult and pediatric patients at Providence, Alaska. So Jared, if you would want to start your presentation, it'll be on CFF overview and research updates.
Okay, I think everyone should be able to see my screen right now, I hope. It is great to be here this morning. And again, thank you to the CF Foundation for inviting me to speak. I always look forward to being part of this event and just imparting a lot of the updates that are occurring in this exciting time. So today, we will be discussing a lot of the newer updates over the last year. Of course, I think things just continue to get better and better as these years go on. I mean, we know right now the average life expectancy for CF continues to rise. It's now into the 60s, which is just absolutely incredible. And we have a lot of new things to discuss that have just occurred, even over the last few weeks. So again, yes, I'm Jared Weinstock. I'm a pediatric pulmonologist here in Alaska. I'm in Anchorage. I know you would think right now in the middle of January that we would be slammed with snow and cold weather, but believe it or not, this winter's been kind of strange. It's in the mid 40s right now and it's raining and we have no snow on the ground. So very different times here, but again, excited to be here this morning. So I think we're going to jump right into it here and talk about some essentially hot off the press news here in the CF world. So as you may or may not know, over the last few weeks, the FDA has now approved a new once a day CFTR modulator. So essentially almost like a next generation Trikafta. The name of this is Alyftrek. It is approved for people with cystic fibrosis, ages 6 years and above. The same mutations that initially were eligible for Trikafta are also eligible for this new modulator. But in addition to those mutations, there are also 31 other rare mutations that have not been approved previously for other modulators that this new one is also eligible for, which is super, super exciting. The big hallmark feature of the new modulator is, of course, it's once-a-day dosing, which I think will become very, very appealing to many people, of course, and prevent any missed doses that may, occur with even twice-a-day dosing that we know Trikafta is accompanied by. And as far as the clinical trial results go with Alyftrek, the improvements in lung function are pretty similar to what we see with Trikafta. The biggest thing has been a reduction in sweat chloride levels that have exceeded even that with Trikafta, which I would expect to correlate, with hopefully even overall improved clinical symptoms with the new modulator. Of course, we have to remember there is a box warning attached to Alyftrek and also to Trikafta now because of the risk of liver injury and liver failure. But we do have guidance to monitor these levels on a monthly basis for the first few months, and then, of course, every 3 months thereafter for just a little bit, just to make sure that we do not have to make any dose adjustments and that it is safe for people to continue on. So again, super, super exciting. This has been the newest development over the last few weeks, which is great to see. And again, as far as Trikafta is concerned, there have been 94 additional rare CF mutations that have been approved for Trikafta. So this has allowed another few hundred people to now become eligible for Trikafta, who again previously were not eligible for this. So you might ask, well, how did this development occur? What has made these 94 additional mutations possible for Trikafta to treat? And I have talked about this before in previous talks, but there is this type of lab testing called theratyping, whereby again, in a laboratory setting, certain mutations from nasal brush biopsies typically we look at the cells in a lab setting and we expose them to Trikafta to see if certain mutations will respond to it. And again, using this type of testing, Trikafta now has another 94 additional rare CF mutations. And I know in my clinic, we've had 2 adult patients with CF who are now eligible for Trikafta over the last month or 2 because of this, which is very, very exciting. So we know that Trikafta, again, has been on the market now a little over 5 years. It's now down to ages 2 years and older who have at least one copy of these specified mutations. And again, similarly to what I just mentioned with the newest modulator, Trikafta does have this box warning now for liver injury and liver failure. But again, we have the right guidance to go about monitoring and making sure that everyone is safe on the therapy. Want to touch upon, again, something hot off the press over the last few months in terms of the genetic therapy space. And we're going to spend some more time on this in the coming slides. But the CF Foundation continues to pour in a lot of money for genetic therapies. This is essentially the next generation, I think, of CF treatment and hopefully, again, leading to that path to a cure. So Recode Therapeutics is a particular company that the CF Foundation has been investing additional funds to, and specifically looking at this gene editing therapy. So what's a gene editing therapy? So a gene editing therapy would essentially go into the cell and correct the mutation that is abnormal with cystic fibrosis. But the interesting thing or the fascinating thing with Recode Therapeutics product here is that it's hopefully being optimized for delivery to what are called the lung stem cells. Stem cells are super important in the body because these help create new lung cells to replace damaged or dying ones. So if we can help restore or fix the recipe for CF in these lung stem cells, well, then the lung stem cells will go on to then create the new and correct form of the cells, which is fantastic. So again, these are an ideal target, these stem cells, for permanent gene editing therapy. And this is what Recode Therapeutics is looking into. Now, it's important to remember here, right now, these are early stages. So the companies are really just targeting the lungs for gene correction. So we still need to come up with a way to target the entire body. But again, if we see that this works, I think with the lungs, I think this will be a huge stepping stone towards that cure. Newborn screening has really, really taken off over the years, as you may or may not know. And there has recently been this newborn screening initiative for CF, whereby the CF Foundation continues to push for, again, early diagnosis. It's super, super important, right? We now have modulators that go down to, you look at Kalydeco, even a few months of life, which is really phenomenal. So if we have an early diagnosis, we can get people started on therapy super early and prevent the delayed diagnosis and the progression of the disease. So we know, again, that the CF Foundation is working very hard with states and helping to develop guidelines for CF newborn screening so that we can improve the screening methods within the states to ensure that hopefully all of the states are aligned with what we would be hopeful for to provide the best care for new patients with CF. So again, now we're going to start talking about the overall treatment landscape here and essentially that path to a cure. I've said this before, and I'll reiterate it again. The CF Foundation is the world's leader in the fight against CF. There's a huge commitment here to making new and significant improvements towards that cure. We know in 2023, the foundation poured, nearly $243 million into not just laboratory research, but also preclinical drug development and clinical research as well. So it's the largest amount to date. And you can see here in the graph that, again, a large amount of funds have been poured in, and these are in millions here on the side, towards all different aspects of cystic fibrosis, which is just tremendous to see. Okay, I know I only have a certain amount of time here, so I want to get right into the pipeline and what some of these outstanding developments are looking like right now. So let's look first here at the genetic therapy pipeline. For any of those who were on this call last year or maybe have attended some of my other talks, this list of genetic therapies continues to expand, and there's been progress over the last year here in terms of how far some of these therapies are getting through the pipeline. When we look at research therapies, I mean, therapies in general have to go through certain phases of clinical studies in order to get approved. So typically there are the preclinical studies, phase 1, phase 2, and then phase 3, and finally, usually to the patient once it's approved. So you can see here these first few genetic therapies, which by the way are all inhaled gene therapies. So again, focused on the lungs. You can see some of these are continuing to make progress into phase 2. Again, patients are being tested with these therapies, and some of them are looking very, very promising. So let's look at some of these in more detail on this slide here. So that first therapy in the gene therapy pipeline is one that's called ARCT-032. This is coming from Arcturus Therapeutics. It's an inhaled mRNA therapy. So when we talk about gene therapies, in order to properly make the right protein, so that CFTR protein, there has to be the proper recipe in place. So typically we have DNA, which is then translated or transcribed, into mRNA, which is essentially what this therapy is incorporating. And then that recipe then goes on to be translated into the correct protein. So essentially what this company is looking at is to, again, come up with an inhaled mRNA therapy that could deliver the full-length recipe of the CFTR to the lung cells, and then the lung cells use that recipe to then make the functional CFTR protein. So if this all works out for this particular therapy, and essentially some of the other ones that I'm going to talk about, this would work for any person with cystic fibrosis, okay? So not just certain patients with certain mutations, but every person, including those with some of these nonsense or other rare mutations who are not eligible for modulators right now. We talked about Recode Therapeutics on some of the previous slide. And again, Recode Therapeutics is looking into a similar inhaled mRNA therapy to, again, deliver that full-length recipe to the lung cell using what's called a lipid nanoparticle delivery system. I just want to spend a few seconds talking about the challenges that initially we thought we were going to be faced here with gene therapies or inhaled gene therapies in general. Remember, with cystic fibrosis, we have a lot of that thick abnormal mucus, and this could be a barrier for a lot of people to allow the gene therapy to reach the proper lung cells. And also, in addition to that, figuring out how to deliver the recipe. So how do we package it? So fortunately, these companies have come up with various techniques like these lipid nanoparticles, or even using some viruses that we'll talk about in the coming slides as ways to help deliver the recipe to the lung cells so that they can make the normal CFTR protein. Another company called SpliceSense is looking at another type of gene therapy here for people with cystic fibrosis who have what are called splicing mutations. So splicing is a normal thing that happens when genetic material is being essentially, transcribed, translated, all of that into the protein. So splicing involves cutting out really a lot of the junk that does not need to be there. And certain mutations with CF are called splicing mutations, whereby that splicing is just not occurring the right way. So this company, SpliceSense, is coming up with a type of gene therapy that essentially would help to correct the splicing mutation so that the protein can be stitched together in the right way and allow it to function correctly. And then again at the bottom here, along the same lines, but with a company that we're all familiar with, Vertex, who again is responsible for, Trikafta, of course, and the newest one, Alyftrek. VX-522 is another inhaled mRNA therapy looking at delivering that full-length recipe to the lung cells using a lipid nanoparticle system. And this again would work for any person with CF. The study here, interestingly, is particularly targeted to adults with CF who have mutations that are not responsive to CFTR modulator therapy. And we should be seeing some data within the coming months, at least here in 2025, to see what the outcome of that therapy is looking like. And just a few others, just to touch upon pretty quickly, but to show you and emphasize that there are other companies that are striving to, again, come up with therapies that would allow for the correction of CF within the lungs. So we have 4D Molecular, which is, again, an inhaled therapy, but using an adeno-associated virus vector, which has been used in other conditions as well, to essentially help deliver the recipe. So they're looking at something like that. And then some of the other companies listed on here too are also studying some similar types of therapies using different vectors, as well as, again, like I talked about with Recode Therapeutics, some of this gene editing technology, which again would go in and correct the underlying mutation within the lung cells or the stem cells themselves. Okay, so this is a pipeline slide looking at really the modulators that are on the market and showing again that now with the newest one, Alyftrek, on the market, we have 5 modulators that are available to patients with CF, which is really, really super. So again, we know that Alyftrek and Trikafta have looked really the most promising in terms of their data with improvements in lung function and sweat chloride levels. But again, in addition to those that are available, let's talk about this company here, Sionna Therapeutics, which is continuing to look at potentially some other types of modulators that could be even added on to therapies that people are on right now, or again, as an alternative to the therapies that are available. So Sionna Therapeutics is looking at, again, a different type of modulator that targets a different type of location on the protein of that CFTR protein that, again, really could help to correct the CFTR protein and help to improve its function. So there are a few types of products that this particular company is looking at. SION 109 and also 451 that are, again, looking at different areas on that CFTR protein that could be a different type of alternative to those currently approved modulators. So super exciting, again, to keep in mind, and also we will continue to follow that progress to see what the outcomes are. So let's talk about some other types of therapies that are also being developed or that we consider with cystic fibrosis. Remember, of course, we're looking for that ultimate cure, but in the meantime, we do have to deal with some of the other issues that people with cystic fibrosis deal with on a daily basis. So inflammation, of course, especially in the adult population or people that are not eligible for modulators, inflammation is something that is dealt with pretty frequently, unfortunately. We know that inflammation is just part of our own body's immune system to really respond to something harmful or irritating. But with people with CF, a lot of times this inflammation continues and is not reversed or does not calm down, even when they seem to be okay in between infections. a lot of times the inflammation is raging. So there are newer treatments that are being developed that are really looking to help modify or just tone down that inflammatory response so that we can have people really not face a lot of the symptoms they're dealing with on a daily basis, but at the same time continue to fight off infections very successfully. So we're going to talk very quickly about two therapies that are in the pipeline right now for, again, anti-inflammatory therapies. In particular, these two therapies that you see on the graph here. The one by Boehringer Ingelheim, or BI, is a particular drug that's being designed to, again, reduce inflammation in lungs of people with bronchiectasis. We know bronchiectasis is just this term that we use to describe this vicious cycle of mucus buildup, infection, and inflammation, and it really does invoke a lot of damage to the lungs over time. So this particular therapy that is being developed by this company is looking at a certain enzyme that can essentially be blocked by this therapy to help, again, reduce the inflammation and prevent permanent lung damage. And this particular therapy is in phase 2 right now. So we'll continue to watch this and see what kind of data comes out moving forward. Another company called Insmed is looking at another type of therapy called brensocatib. This is another oral therapy that may actually be approved this year or early next year, it's looking like, for people with bronchiectasis. But it's essentially a drug that is blocking a certain enzyme that is made by a type of cell called a neutrophil, which gives off a lot of nasty stuff to help really fight infection, but can also play a huge part in increasing inflammation. So this particular therapy is, again, something that would help to block this enzyme called neutrophil elastase to help, again, decrease that excessive inflammation and hopefully decrease damage that's being caused to the lungs. And again, this is moving nicely through clinical trials right now. Another area that we need to touch upon are the anti-infective therapies. So we know, unfortunately, even with modulators on the market, or especially for people that are not on modulators, we deal with infection quite frequently. We have people that are colonized with certain bacteria that are very nasty at times, like Pseudomonas aeruginosa, and we know that these recurring infections can gradually, over time, destroy lung tissue. So the main issue with CF is that, unfortunately, because of the abnormal mucus, that mucus provides an ideal environment for the bacteria. The bacteria love it, and they end up forming sometimes these protective layers called biofilms that then make the bacteria much more difficult to kill. So the CF Foundation has had an infection research initiative over time, over the last few years now. Again, hundreds of $millions have been poured into this to help improve detection, diagnosis, prevention, and treatment of infections. And some of these we're going to see on the next slide. You can see here a nice laundry list of therapies that are already approved for infection or, again, currently in development right now, and even moving nicely into closer to being, again, available to patients. So let's briefly just talk about some of these that are in the pipeline and not approved yet. There's a type of inhaled therapy looking at preventing Aspergillus infections, which is a type of fungus, especially in lung transplant recipients. We have a lot of challenges right now in treating Aspergillus. The treatments are very hard to tolerate, and a lot of times they interact with transplant therapies. So this particular inhaled therapy is being looked at right now to see, again, if it can be more helpful in warding off the infection, but also, again, preventing any side effects that the patients may face with their other medications. Just quickly here on the bottom are Mata Pharmaceuticals and also Biomics, two different companies looking at what are called phage therapies. So a bacteriophage is a specialized virus in the environment. It's a natural occurring virus that is specifically targeted to kill very specific bacterial strains. So again, they are essentially predators of bacteria in nature. So companies are looking at creating therapies with these bacteriophages that really are targeted right now in the CF world at Pseudomonas aeruginosa and are looking very, very promising. This particular company in lab tests, this therapy using the bacteriophage was able to kill off more than 80% of Pseudomonal strains from people with CF. And if this is something that comes to the market, I think this will be an incredible advancement in the infection world. There's another type of product called IV gallium. Gallium is something that's very similar to iron. It's a type of molecule that can actually disrupt certain processes and also has been shown to kill very resistant strains of Pseudomonas aeruginosa. So that's being looked at right now in phase 2 for people with CF, but it's actually already approved by the FDA for IV use in people outside of CF. So we'll see what comes of this. I mentioned the company Biomics, again, another type of that bacteriophage therapy that may be very, very useful in helping to kill these antibiotic resistant strains of Pseudomonas. And again, it's moving very nicely in clinical trials. So hopefully we continue to see some positive progress there. And finally, there's a company called Claramedics Biosciences that is also looking at a type of therapy to help disrupt that bacterial biofilm. Remember what I said earlier, in people with CF, with that abnormal mucus, the bacteria, they're smart. They develop these biofilms, and then it's super, super hard to kill them off. So this particular company is looking into a way to help really disrupt that biofilm so that therapies can work to essentially kill these bacteria. And finally, in my last few minutes here, in the nutritional space here for CF, remember, we always think lungs, but the GI tract is super important with people with CF. We know that pancreatic insufficiency affects about 90% of people with CF. There's funding being looked at right now. We'll talk about it in the next slide or the slide after that, in terms of developing a different type of pancreatic enzyme replacement therapy that is non-porcine, and that may have better dosing, really even maybe one enzyme replacement therapy with each meal versus this incredible pill burden that exists right now. So we'll be paying attention to that. And then there's this huge trial right now called Galaxy that's being looked at to help us really with adults that are suffering with malnutrition, looking at constipation in CF, small intestinal bacterial overgrowth, and also the use of proton pump inhibitors with CF, just to help give us some more guidance here. We cannot ignore things like cystic fibrosis associated liver disease. This affects about 10% of people with CF, and there's a lot of research underway to help us identify this earlier so that we can minimize liver damage. And colorectal cancer, again, adults with CF have a 5 to 10 times greater risk of this. And in somebody who's had an organ transplant, that risk even goes 25 to 30 times. So a lot of research is being conducted right now to understand that mechanism. And again, help to provide us with the right guidance and maybe even treatment for this. This is the pipeline for the enzyme replacement therapies. Really, the one that I was talking about on the earlier slide here is this therapy by Anagram Therapeutics, which is that non-porcine or not pig-derived enzyme replacement therapy. So again, does not contain any animal products, and it may improve the dosing convenience by reducing that pill burden compared to the available enzyme replacement therapies right now. Still very early on in trial, but it already has completed phase 1, and it seems to be very safe, tolerable, and effective with a single dose. So we'll see again what comes of that study as it continues to move on. And finally, I'll conclude here and then hopefully maybe a minute or two of questions and maybe some more at the end if there's time. Again, acknowledging CF Foundation continues to do an incredible job here in really supporting this broad range of research initiatives. But again, aside from trying to find that cure, a number of unmet needs remain, and this is just some of them here that I've listed. We already talked about the pill burden with pancreatic insufficiency, CF liver disease, CF-related diabetes, some of the side effects associated with modulators. But again, most importantly, again, continuing this journey until, we find that cure, and CF stands for Cure Found. So with that, we'll open it up to some questions. I hope, Christy, I didn't go over too much. But I know that's a lot of information for everybody, so we'll open it
That's
up.
great. So many exciting things happening. So thank you so much. I did see one question come in, and we are maybe just have a couple minutes here, like you said, but this one is, so if anyone has more, you can continue to put them in there, but not too much time. Anyway, this question, gene editing for CF sounds promising, but what legal hurdles could it face? Will it be affordable and covered by insurance, or only accessible to high income families? And this one's from our friend Hogan. She says, I know you probably don't have all those answers just yet, but thinking to the future.
Right. Yeah. I mean, it's super, super early. Of course, I think right now it's very localized, so it's to the lungs. So, compared to other gene therapies, gene editing therapies that are on the market for other conditions, a lot of like neuromuscular conditions have these available right now. And from what I've seen, they've been super accessible for those that qualify for it. They are super expensive. You're talking millions of dollars, especially for the therapies that are systemic, meaning they are like one-time infusions to essentially, hopefully, provide a cure. But insurances, from my experience, like I see a lot of patients with other, of course, diseases outside of CF that have received these things, and they have received it with no major insurance issues, regardless of their type of coverage. Fortunately, of course, it may require some authorizations and paperwork and all that, but as far as I'm hopeful right now for the CF therapies, and at least with the inhaled gene therapies, the data is looking promising. And right now, some of the studies with some of the companies are even looking at using the inhaled gene therapies on top of the modulators. I know I mentioned Vertex looking at it for people that are not eligible for modulators, but most of the other studies are actually looking at it as add-on therapy as well, in addition to those that are ineligible. So I think if we have the data to support it, and we have the indication, I don't think we should have any super pushback from payer support.
Great. A couple more have come in. So this one is there an official recommendation for earlier colon cancer screening? I think it's colon screening in adult CF patients.
Yeah, I mean, right now there's guidance that's out there to start screening at age 40. So I think that's super important. We make sure that's part of our discussion with patients. I think, the discussion can be, individualized if there's, more concern to do it any earlier than that. But typically right now we start at age 40 and then go from there. If everything seems to be okay on the initial colonoscopy, then typically we just continue to follow the guidance with monitoring and all of that. But it's super important, just given that increased risk or chance of colon cancer and CF, super important to start screening when the time comes.
Great. Okay, a couple more. Has the incidence of CFRD, CF-related diabetes, decreased for those who have been on modulators since an early age?
So I think it's still, hard to say right now. I mean, again, we have Trikafta out 5 years. I think for the most part, at least looking at some of the young adults that I've seen that have been on Trikafta the last 5 years, I'm still seeing incidents of CF related diabetes. I don't think it's plummeted to a significant degree. I think it's something that we still need to deal with. Again, very similarly to pancreatic insufficiency. I really have not seen tremendous improvements with being able to take people off of enzyme replacement therapies or even decrease doses. I'm hopeful maybe as these modulators continue to be studied for very younger populations, maybe the earlier we start them, the better. But I think the pancreas is taking a hit even in utero before the children are born. So it's something that still remains to be a huge unmet need, until we find, essentially a cure for CF.
Okay, thank you. We have time for one more. There's two that I'm combining into one because it definitely has to do with the liver. So one is, do we know the liver injury and disease, if that risk is different for Alyftrek versus Trikafta? And then also kind of in that same category, due to the stress on the liver, would there be a reason to delay taking a CFTR medication if the patient doesn't have any known lung damage? Big
So
questions.
yeah, so I mean, so Alyftrek is again a triple therapy, very similar to Trikafta, but it has essentially different types of those ingredients in the newer therapy to allow it to be once a day. So from the study that has been conducted, it just appears to be a very similar risk to Trikafta in terms of that potential liver injury and liver dysfunction. But I think again, adjusting and making that black box warning, present is allowing us to be more vigilant of that and more careful as we start people on this, watching the liver function much more closely than previously. Remember, even with Trikafta, we were looking at it every 3 months for the first year, and then of course yearly thereafter. But I think again, this is good guidance that we have now. Just knowing, I guess, with the it's not a large number of people, but we want to make sure that we're using these safely. I think in terms of delaying the initiation of modulators, I think we have to consider that the benefits there, even if somebody's doing super well from a lung perspective, remember the modulators are not just affecting lung health. We've seen tremendous effects from nutrition, growth, all of that. You know, years and years ago, before the modulators, especially Trikafta was available, people suffered, you know, with being able to maintain a healthy weight. And now we have people that are actually gaining too much weight on the modulators. So I think we have to remember other aspects that the modulators are also treating, not just lung health. So my advice would be to start as soon as somebody's eligible.
Great. Well, thank you so much, Dr. Weinstock. We always love to hear the overview. Again, so much exciting things going on. We are going to move on to our next speaker. We've got Dr. David Ricker, pediatric pulmonologist and director of the CF Affiliate Center at Marybridge, Tacoma. And he has been there for over 30 years. And he's going to talk today about aquagenic wrinkling in CF.
Hey, can you see my screen? Does it work?
Yes, we see your screen. It's not in present. Yep, there you go. Like not presentation mode yet.
Not in present. Okay, let me try and get that.
Looks great.
And how's that? Is that better?
Now we're seeing your next slide. So,
Oh, okay.
yep, that one. There you
How's
go.
that?
Perfect.
Is that good? Okay. All right. Boy, first of all, shout out to Dr. Weinstock for a great talk. That was fascinating. Covered a lot of ground, interesting stuff. My talk will not be covering groundbreaking research so much as, but hopefully it'll be some interesting stuff. So we're going to talk about aquagenic wrinkling in cystic fibrosis. This is also known as aquagenic wrinkling of the palms. As Christy said, I've been a pediatric pulmonologist at Marybridge for over 30 years. I'm the director of our CF Affiliate Center. Part of the reason for choosing this topic, there's some interest there. And I've been a CF physician for quite a while, but only heard about this fairly recently. You know, so often as physicians, we learn from our patients, and one of our patients really struggled with this. And so that's when I first started learning about it. So we're going to talk about what is aquagenic wrinkling and why are we even discussing this. We'll talk some about why, when people started writing about this, how it happens, what can be done. And this is going to be a fairly short talk. So hopefully I'd be very interested in hearing if people have experiences or thoughts or even questions. It's something that has come up in clinic visits, not as a, as a main topic of discussion, but kind of as a secondary issue. So I'm interested in hearing about people's experiences. So aquagenic wrinkling is a rare dermatologic condition that's characterized by excessive wrinkling and swelling of the palms, and the palms get whitish papules, some plaques. I'll show a couple of pictures, and this occurs after pretty brief immersion of the hands in water. It can be accompanied by pain, itching, discomfort. As I said a few years back, we had a patient that it was quite bothersome for. It's typically involves the hands, but the soles and other body parts can be affected. And typically most cases resolve within 20 minutes after taking your hands out of water. So this is a picture on the left side. This is somebody with cystic fibrosis before putting their hands in water. And the second picture, next picture, is after placement in water, 5 minutes of placement in water. And you can see that kind of that exaggerated wrinkling, kind of to on the sides. You see that kind of whitish, raised, bumpy appearance of the palm. And this is from one of the dermatology literatures. Another picture where you just get this exaggerated wrinkling of the palms. This is from a dermatology journal. So you get these dermatologic phrases with keratotic basically means kind of thickening and rough, where you get these pebbly white plaques, just the areas where it's just kind of a white accumulation there. So why are we talking about this? It turns out that aquagenic wrinkling is primarily associated with cystic fibrosis and can be associated with CF carriers. Based on the literature, the range of prevalence in CF is 41 to 84% of people with CF. Most more recent articles indicate that it's probably more common than less common, but 25% of CF carriers would exhibit this as well. And again, when I first learned about this, I wondered why don't we hear about this, or why doesn't this come up more often? And one of the articles, a quote from the article, is that Patient Questions felt that despite being symptomatic, aquagenic wrinkling was too trivial to address at clinic appointments. And you know, in reviewing the literature, one of the interesting ones, it was a case report of a young man from Puerto Rico. And of course, and this was a young man who had not been diagnosed with CF yet. Of course, newborn screening in Puerto Rico started after, much later than it did in the 50 states. But anyway, he started a new job at a car wash, and his wrinkly hands were a bothersome symptom to him. So first, aquagenic wrinkling is first described in 1974. It was just a one-paragraph letter to The Lancet, which is a prestigious British medical journal, but the letter was just titled "Wrinkling of Skin and Cystic Fibrosis." And so this is almost 40 years after cystic fibrosis as a diagnosis is described in medical literature. It's thought to be more often associated in females than in males, and actually first male with aquagenic wrinkling was reported in 2005 in the literature. And then in 2008, there's a paper published by Guild where they did a study with 49 people total, and they would have them immerse their hands in a bucket of tap water, and found that people with CF, average time to wrinkling was 2 minutes. You know, if you didn't, and then if you didn't have CF, I mean, the average time to wrinkling was 11 minutes. But interestingly enough, the carriers were in between. CF carriers would have wrinkling of their hands, an abnormal degree of wrinkling in their hands after 7 minutes. And there was enough difference that this was found to be very significant. So it couldn't just be attributed by chance. So there's not a complete agreement why this occurs at all. It's thought that it is related to the defective CFTR protein, the cystic fibrosis transmembrane regulator protein, such that there's less electrolyte reabsorption into the skin, so the sweat is hypertonic or more salty. And the thought is that this affects the epithelial skin cells such that there's increased diffusion of fluid into the palmar skin. There are additional mechanisms which I won't go into because I don't fully understand them. There is some thought that perhaps the local nervous system may be involved as well. And although I said that aquagenic wrinkling is primarily associated with cystic fibrosis, it can be associated with medications that affect sodium retention in cells. So that would include aspirin, selective cyclooxygenase inhibitors like Celebrex is an example of one, ACE inhibitors. It can also occur in some disease states such as severe malnutrition or atopic dermatitis. Atopic dermatitis is also known as eczema. So what can be done about it? 20% aluminum chloride solution can be used. It comes in a lower strength as a gel. For some people, the 20% aluminum chloride solution is irritating. These are sometimes prescribed also for people who sweat excessively. Gloves or barrier cream such as petroleum jelly can also be helpful. But there's a couple of fairly recent articles looking at the role of CF modulators, specifically on aquagenic wrinkling. And so in 2022, in the Journal of Cystic Fibrosis, there was a report of 16 patients who had anywhere from mild to severe aquagenic wrinkling, and that improved in all to some degree after 6 months of ivacaftor. And then I mentioned our case report, the 16-year-old young man from Puerto Rico who worked in the car wash. He was started on Trikafta and had improvement in this symptom. And so, you know, the top pictures A and B are after 5 minutes of putting his hand in a bucket of water before starting Trikafta. Picture C is after 6 months of Trikafta. And you can see on A and B, there's kind of a lot of wrinkliness and bumpiness to the palms. And you really don't see much of that at all in the lower picture. So the take-home points would be that aquagenic wrinkling, it's common in both patients with cystic fibrosis and is also seen in CF gene carriers, and that's probably relates again to the CFTR function being affected somewhat even in CF gene carriers. So, and because of that, because it's thought to be related to the CFTR dysfunction, it would be likely expected to respond to the highly effective modifier therapy. And again, there's a couple of articles that would concur with that. And then lastly, the presence of aquagenic wrinkling. Several of the articles I reviewed suggest that its presence, if there's not a CF diagnosis already in place, that should prompt screening for cystic fibrosis. I even found an article from 2021 from Greece that promoted, immersing in hands in water, looking for aquagenic wrinkling, promoted that very much as a screening test. So these are my references, which range from 2005 up to most recent in 2022. So I was actually surprised to find out how much had been written about it, and written fairly recently. Again, this is I wanted to just bring this up on a short talk because I think it's interesting, and I didn't learn about it until fairly recently. But appreciate everyone's attention. I'd be happy to answer any questions. I'll also be happy to, hear if other people have experienced this, if it's an issue or not.
Thank you so much, Dr. Ricker. I am trying, we'll see if this works. I made a poll to see if people can answer if they have had this or their person with CF has had this. So if it should pop up, I think if you guys want to take a poll. Oh, we got some yeses. Okay. And then in the Q&A, we've got on the general topic of CF electrolyte reabsorption, is there any research that shows CFers would benefit from consuming more electrolytes via powder supplements like Liquid IV, Element, it's probably Element, and Noon? Any thoughts on that, Dr. Ricker? If more electrolytes would be helpful?
If extra electrolytes would be helpful? Sorry, I missed it.
Yeah.
I would imagine so, maybe. I mean, they might just be lost in sweat. I don't know. I don't know. Perhaps none of the articles I read suggested that as something to treat or ameliorate it, but it's a good thought, but I don't know. Yeah,
I recently got on the Liquid IV train. It's really keep me hydrated. And then another question is, water temperature a factor? And then Mark said swimmers. So Mark, if you wanted to come off mute and confirm a little more, but if you, Dr. Ricker, you can talk about the water temperature first.
I think just from the literature review I did that this is more of an issue in cold water exposure. Well, yeah, but I'm not sure. That's not something that, yeah, I don't know. It's a great question.
There's a lot of CF kids that swim, and just sort of wondered about that.
Yeah, I think it's fascinating, all the different parts of CF, because as Dr. Weinstock was saying, you know, we think of the lungs and the digestive system, but there's so much more, you know, that's all happening. It's a whole body disease. And Sam, it looks like you have your hand up. Do you want to come off mute?
Hi, Dr. Ricker. Just wanted to say hi.
Hi.
This was something that we noticed with our kids, Ben and Elena, who started at Marybridge all those years ago. We moved
Yeah.
to Spokane in 2010. So
Yeah.
Elena was diagnosed in 2003 when she was 6 months old, and Ben was born in 2006. So now they're 22 and 18, just to let you know, and Ben just graduated high school. But yeah, this is something that Bob and I noticed when they were babies and you know, toddlers, and after bath time, and we would look at their hands and they were so wrinkly, like, and we just assumed it was something with the imbalance of the salt in the skin and all that. But we noticed it, and then it went away, and it was never accompanied with any pain or any discomfort that they shared. But we saw that with both of our kids and just thought it was interesting. So it's cool to see that there's research and that it's a known symptom of many people. That's it.
Thanks for sharing, and say hi to your kids. Glad.
Yeah,
Thanks for the update.
Okay, one last question here. With Mark shared that there's a lot of CF patients that swim. This is kind of a little off topic, but so you can defer, see if this will be a good one for you. But so a lot of people with CF might be swimming, but this person said they've been told to avoid natatoriums. Can you talk more about these risks? I don't know if I said that right.
Well, I don't know if you said it right either, because I'm not entirely sure what a natatorium is. I'm going to guess that it's a
Pools.
Indoor, yeah, pools, indoor swimming pool. It's a great question. I think, you know, this is the sort of thing where you know, if you ask 5 different CF doctors, you might get 6 different answers. But you know, historically, CF docs have had a lot of exposure to water sources, especially in particular hot tubs. I mean, and that's primarily been related to potential for Pseudomonas exposure. Pseudomonas means water loving, and you know, of course, Pseudomonas aeruginosa is known to be, you know, potential cause of lung injury, lung damage in CF. So you know, we highly worry about that. So you know, I think as a CF doc, I have historically encouraged my patients to avoid hot tubs. I think exercise is great, and swimming is a great form of exercise. So I've never encouraged anybody to avoid indoor swimming pools because of the humidity. Would there be a higher risk of Pseudomonas? I suppose so, but you know, that may be outweighed by the benefits of being active and exercise. So it's a great question, but I don't think there's a clear-cut answer.
Great. Well, thank you so much. We are going to move on to our next speaker. Appreciate you, Dr. Ricker. Next up, we have Dr. Sid Kopnatik. He is an associate professor with the University of Washington School of Medicine and director of Adult CF Care Center. And he's presenting today on aging in cystic fibrosis.
Thanks, Chrissy. Can you guys see my screen? Am I in the right mode and everything?
Yeah, looks perfect.
Okay, great. Well, yeah, thanks for having me, and thanks for everyone for coming today. I'm going to be talking about aging in CF, and I think it is kind of a fun topic. Aging, in and of itself as a concept, maybe not the most fun topic, but I think the fact that we're talking about this and as a reflection of how much outcomes have improved is super exciting, and hopefully this will be informative for you all. So outcomes are indeed improving. This graph shows that our average lung function trajectory by birth cohort and era and by age. And you can see that back in the early 90s, this was kind of our median or average lung function trajectory. And you can see this has kind of slowly increased over the years. And here in the most recent cohort, people who were born between 2014 to 2018, you can see how high it is and how stable it is thus far. So this is great to see. And this is translated to adults being a quickly growing part of the overall CF population. And look at back in the 90s, early 90s, where about 2/3 of people with CF were children. And now that number is nearly flipped, where adults now in 2023 made up about 60% of the overall population. You can see how quickly that's rising. And when I say, the adult population is growing, we're not just talking about people who are, 18 or 20 or 25. We're really seeing a ton of people living and kind of well into adulthood. And I have older in quotation marks here because, what does that really mean? But this graph, which is actually from the Canadian Registry, shows age here at the bottom and the number of people at each age with these blue bars. So number who are age 5, 10, 15, etc. And in 2022, it was almost a quarter of people, and this is from the Canadian Registry. I just liked kind of the way it's displayed here. By 2022, it was about a quarter of individuals with CF who were over the age of 40, and you can see how many people lived into or are living into their 50s and 60s or even 70s. So this is really, really amazing to see this. Modulators are, of course, a huge part of this, especially over the past few years. And we've seen huge improvements with modulators. And one of the kind of reassuring and exciting parts is that these improvements so far in your average patient seem to be sustained, which is really, really great to see. And this is from this yellow portion here is from one of the original randomized controlled trials where people either got a placebo medication or elexacaftor, tezacaftor, ivacaftor, which I've abbreviated ETI or Trikafta here. And this blue line were the people who received ETI, and the gray line were the people who received placebo. You can see how much the symptoms and the lung function down here at the bottom improved compared to the placebo. And then after this original study, all of the people in the study were switched to ETI. And then it shows the 3-year follow-up period, and you can look at how stable the symptoms are. So, and the lung function. So it's not as if they went up and now we're starting to see a decline. At least in this study, we can see how stable it is, which is really amazing. And with all of this together, the future is certainly bright for people with CF. This shows our median predicted survival by birth cohort, and of people born with CF in 2023, it's actually predicted that more than half will live to longer than 68. And you can see how that line is steeply rising, which is awesome. Okay, so there's no doubt that we'll have an older population here in the future than what we've been used to. And a lot of things are probably going to look quite different. This includes living longer with well-known CF conditions. So what do these things look like as people get older? We'll have to think about new conditions that may develop with age and with time. An evolving model of care. So how can we most effectively deliver care to our individuals in our clinics, as well as new treatments, including for those who are currently ineligible for modulators. And Dr. Weinstock went over that last bullet in some detail this morning. Sorry about that. Up. Something with my kids. They're probably some sort of argument. Sorry about that. I had a block of time that they weren't supposed to come down, but you know, that's how it goes. So I'm going to really focus on these first three bullet points here. Okay, so these are, what do I mean by living longer with well-known CF conditions? So these are conditions that we know very well to be associated with CF. We've kind of been dealing and handling these issues for a number of years. So things like lung disease, gastrointestinal symptoms, sinus nasal problems, pancreatic insufficiency. We know about these conditions well, but what we know about them is really based on how they've looked in the past, and mostly in younger people with CF. We'll definitely need to understand how they look and how best to treat them as individuals get a little older. And I'll review this concept in more detail in the talk. What about new conditions? So these, of course, aren't new medical conditions. In fact, these are important considerations that are really confronted by all people as they age. But they were never really a focus in the past for people with CF or their care teams. And now I think we need to kind of understand how frequently these issues occur and how they look in CF so we can understand how best to manage them. And I've shown some examples here: cardiovascular disease, chronic kidney disease, cancer, obesity, and some of the other issues that we may think about. And then I'm going to circle back to this a little bit later. So which conditions should we be focusing on in an overall CF, in the overall kind of older CF population? So I would say that these should be conditions that are confronted by all people as they age and become more frequently, because we may start to see some of these things in CF. Any conditions that impact symptoms, cause symptoms, and impact quality of life. And then, of course, conditions that could increase the risk of death. So on that last one, these data are from the CDC, and they show the leading causes of death in the United States in 2022. And you can see heart disease is the top cause, and then stroke is just slightly under that. And these are cardiovascular problems. And I think we should recognize that cardiovascular disease becomes more common in all people with age. With that said, cardiovascular disease has been historically uncommon in people with CF. So we've never really had to think much about this in the past in most people. Why is that? Well, when we think about the risk factors for cardiovascular disease, I've shown some of them here. CF has historically had sort of a positive effect or lowering effect on these risk factors. So things like, age is a risk factor for cardiovascular disease, but historically we haven't really had to think about people with CF living into their 50s, 60s, 70s. High cholesterol. So cholesterol has actually been historically low in people with CF. Obesity has been very uncommon. Smoking, I would like to think, has been uncommon in people with CF. High blood pressure, that's not really been an issue we've had to think about. Unhealthy diet, that's sort of a question mark. I think, for many people, we've used this kind of legacy diet with high calories and fat-containing foods. And then diabetes, we do see an increased risk of diabetes with CF. So, but putting all of these risk factors together, we've seen very low prevalence of cardiovascular disease in CF. We are starting to see changes in these risk factors in the new era of CF care. So this was from a study that looked at weight before and after ETI or Trikafta, and the number of people who were underweight went down, which is great. But we saw an increase in the number overweight and obese here. And these are data from the CF registry, which shows kind of a similar trend where people who are underweight has decreased, which is great. But then in the green and the blue bars here, we've seen a sort of an increase in the number of people who are overweight. And it was about 40% in the registry in 2023 compared to about 25% in 2013 and about 17% in 2003. Now, this is nobody's fault. First of all, it's common in all people with age. But second, and specific to CF, many people, like I said, have been constantly kind of pushing calories for years. Not everyone, but many. And now with improved health and modulators, it's been difficult to adapt for some individuals, which, of course, how would you expect it to be any different? It's such a change here over the past few years. What about CF-related diabetes? Well, we know that this is a common issue in adults. And so I would characterize this as kind of a well-known condition. And this shows the percentage of people in the registry with CF-related diabetes here in the blue line, and impaired glucose tolerance with age. And you can see it's about 40% by age 50 who have CF-related diabetes, with another 10-15% with impaired glucose tolerance. So this is a well-known condition, but it's a well-known condition that may look different in the future. So what types of things are we talking about? Well, first, modulators can improve CF-related diabetes control. So that's great. We have seen some improvements in hemoglobin A1Cs. However, weight gain can prevent insulin from working properly. So if people gain too much weight, we may start to see insulin resistance and more sort of features of type 2 diabetes. I think we should note that only about a third of adults who are not diabetic currently receive the recommended screening. And that's just a large part of that is just because of how hard it is to get glucose tolerance tests. It's not a test that's easy to do. And then I think we need more awareness of longer term complications. So cardiovascular issues, eyes, kidneys, nerve issues. And so just awareness of these things so that we know what to look out for and how to optimally manage individuals with CF. Here are a couple of other considerations. We have seen slight upticks in cholesterol after ETI. It's not a huge uptick, but it's just something to kind of watch for. We've seen a small increase in the number of people who have high blood pressure or hypertension. So this was from a study looking at blood pressure before and after ETI, and you can see the number who had normal blood pressure went down, and the number with stage 1 or stage 2 high blood pressure went up. So like I said, we'll just need more awareness of cardiovascular risks in the modern era of CF care. When you look at our table here, these are some of the new considerations that we should be thinking about. So let's just be aware that the cardiovascular risks tend to increase with age, and we just need to kind of think about it. Not to say that it's going to affect everyone, but just sort of have it on the radar, just so that we can optimize risk factors. We should be thinking about a healthy diet, healthy lifestyle, regular exercise, and kind of preaching to our patients that this is something we should sort of institute this lifestyle as early as we can. We should be aware about cholesterol testing and awareness and blood pressure monitoring. So they've actually added a field in our CF registry to start regularly entering cholesterol levels into the registry, which is a new change here over the past few years. And then regular diabetes screening as much as possible, awareness of type 2 diabetes, and then monitoring for complications. Okay, so then going back to this slide, you can see that cancer is another leading cause of death. And I think this was mentioned earlier in Dr. Weinstock's talk, and there were a couple of questions about it, but CF can increase the risk for colon and some other cancers. So this was from a study that looked at the risk of bowel cancer by age in people between 1990 and 2009. And you can see that this line of people in the CF registry started to increase at an earlier age. So this is all types of intestinal cancers, with colon being the most important. You can see the CF registry compared to the overall population. And so colon and other intestinal cancers seem to arise at an earlier age and a higher rate for people with CF. So why is this the case? Well, the CFTR chloride channel is actually thought to sort of exert some tumor suppressive properties. So it actually can help, if the channel is functioning properly, it can actually help prevent tumors from developing. And then if we lose that function, it can sort of put people at a higher risk of cancer. Some of the other mechanisms that have been postulated include inflammation and changes in the immune system, changes in the microbiome or bacteria in the intestines. And then for people who have had transplantation, lung or liver transplant, the immune suppression can actually increase the risk for cancers. Some other points are that many cancers become more common in all people as we age. And then lastly, we don't know how modulators are going to affect the cancer risk. You could imagine a scenario where, because the chloride channel starts functioning better, perhaps it would reduce cancer risk, but we just don't know that at this point. So what are some considerations in the modern era of CF care? Well, first, I don't think this is cause for alarm or sort of getting super worried about it, but I think it's more just knowledge and the fact that, and I should say that many of these cancers that CF increases the risk of are rare. They're still rare. They might be more common than in the overall population, but they're still rare. So it's not a cause for alarm, but I think it's more just a matter of education and making sure that we're doing the proper steps to prevent cancer. Important to note that many cancers can be found and treated effectively with proper screening. So colon, we touched on earlier, breast cancer, cervical cancer, skin cancer screening is recommended for people who have had a lung transplant. We touched on this earlier in Jared's talk, but it's recommended that colonoscopy start at age 40 for all people with CF, or actually age 30 if they've had a transplant. And then it's recommended to repeat the colonoscopy at least every 5 years. A healthy diet and lifestyle, so avoiding smoking certainly, but excessive alcohol and just having a healthy diet can reduce the risk of some cancers. And then just lastly, we'll need more information in the coming years. So our knowledge on this may evolve over the next several years. Okay, so changing gears here and moving to women's health, which is arguably a topic that hasn't received that much attention even in the prior eras of CF care, but now there are new considerations. So there have certainly been many positive changes with improved health and treatment, and one of which is the fact that more women with CF are now able to have children and families. So this shows the number of pregnancies by year, 2013, 14, 15, et cetera. And you can see here in 2020, which was coincidentally when ETI was first approved, you saw this big bump. So this so-called Trikafta baby boom. So this is amazing. So, this was not something that was easy for people in the past. Still not easy, but it's a wonderful advancement in care. Where can we improve? Well, first, it's been documented that up to 50% of CF pregnancies are unplanned. And sort of attached to that point is that genetic counseling and family planning assistance don't seem to be routinely available or offered to adult women with CF. So it's a resource issue many times. So many of our clinics don't have easy access to these services, but it's not ideal, and it's something that we can improve upon. And then it's also been shown that women with CF less often receive some aspects of routine gynecologic care. So things like discussion of contraceptives, screening for sexually transmitted infections, cervical cancer screening, and discussion of issues specific to menopause. So why haven't we been great with these things? Well, we haven't really been thinking about this sort of adult CF population. And, is it really a priority when we're trying to kind of keep lung health steady and pancreatic and nutritional health steady? So these have sort of fallen back sort of on the back burner. And some of it is because, as CF providers, we're not necessarily experts in some of these things. And so we're less comfortable kind of talking about these issues. Now, in terms of menopause, low bone density is certainly an important issue. We know that low bone density is common, and it's one of the so-called well-known conditions that have been long-standing associated with CF. But it's very important that to recognize that low bone density gets more common with age, as shown here in the graph of people in the registry. You can see the slow increase in the percentage who had low bone density or a fracture. The fact that it is more common with age is not specific to CF. It's just something that occurs in all people. And the same is true in all people after menopause. But it's not necessarily something that is systematically addressed as well as it could be in CF clinic. In fact, it's been shown that about 40% of adults have not had a DEXA in the past 5 years, which is the recommendation. This is something we could do better as providers, and our program kind of recently looked at our own data, and this was the University of Washington Center, and we looked at the number of people, the percentage of women who had not had a DEXA in the past 5 years by age, and we're doing okay. I mean, we're better than the national average, and you can see as people get older, the percentage sort of decreased here. But one of the things that was a little disconcerting is that we saw this uptick. So in people over the age of 60, we actually had about close to 20% who hadn't had their DEXA in the past 5 years, compared to only about 10 to 12% in these younger ages. We kind of expect that in the people in their 30s because it's not quite as important, but it was sort of disconcerting to see this uptick. So we recently, this was spearheaded by our amazing dietitian, but our program recently started a QI project to kind of identify menopausal transition and ease conversations regarding issues that become more common after menopause. So things like sleep changes, energy, hot flashes, and importantly, bone density, which is something that's a little bit easier to track and that we'll be monitoring in the coming years. So again, as a CF doc, this is not something that is necessarily in my wheelhouse. My knowledge about postmenopausal care is not it's not one of my strengths, and I don't think I'm alone on that. And I think for that reason it's kind of fallen to the back burner in the adult clinics. But as people with CF or caregivers, I think it's important to just know about you can call this out and talk to your teams about this, and hopefully they'll be receptive. Okay, so moving on, and mental health and social considerations with age could be kind of a whole talk or multiple talks, but I just wanted to highlight a couple of things. First, I would think of these as very well-known, kind of important topics in CF for many years. We know that depression and anxiety are common in people with CF, and they've been linked with worse outcomes in both CF and other diagnoses. Importantly, it doesn't seem that modulators appear to be linked with worsening mental health in the overall CF population. This was from a study from actually Dr. Ramsey from our children's group published a study last year. And this graph shows the percentage of people in the CF registry with depression by year in relation to starting ETI. So this was the percentage, in 5 years before ETI, 4 years, 3 years before, and 1 year. And it was actually increasing, which I think reflects just sort of our society right now. And we have seen increases in depression in all individuals. But then you can see the rate kind of stayed similar after starting ETI. And they did a number of analyses in this study, and it didn't seem to be that ETI in and of itself caused problems for the overall population. But there are some caveats and other considerations. So first, studies like this, they kind of document the effect on the overall population, but everybody is an individual and everybody's different, and effects of modulators and age on mental health, I mean, they're going to vary from person to person. So everybody may have a slightly different experience. And I think we as providers and the community should obviously appreciate that. Next, I think we do need to think about new stressors and issues that that become important with age and improving health. So these are things that we may not have really had to focus on in years past. So guilt, survivorship. So this is this feeling of, I wasn't supposed to be here and now I am. How am I processing that? Planning for the future. So, not necessarily a focus when the average life expectancy was much lower in the past. Saving for retirement, raising a family, and just this living with uncertainty. Things are different than they used to be, and it's happened quickly. And I think adapting to these new considerations will be important for us. And then, of course, the fact that many are still ineligible for modulators, and that has its own impacts that sort of are beyond the scope of what I wanted to talk about today. Okay, so what about medications and treatments in the new era of CF care? The people with CF have been used to living with and dealing with a necessity to take a number of treatments on a daily basis. I mean, this has always been the case. And I would think of this as a kind of well-known CF-related condition or experience. Polypharmacy, which is often defined as taking 5 or more medications in a day, is common in CF. And it can be more common as people get older as well, in all people. So first, people are often prescribed more medications with age. That's just a clear sort of trend as people get older. How a person's body absorbs and handles medications can change with age, so that we have to kind of think about that. And then people can become more prone to side effects and medication interactions and prescribing cascades with age. So what's a prescribing cascade? So here's a nice little cascade here. And a cascade is defined as when a drug is used to treat a side effect from another drug. So I'm going to give an example here. This is slightly embellished, but so let's call this a 42-year-old man with CF who started a new inhaled antibiotic, which causes a cough. So the cough persists for a while, and the person eventually gets a course of prednisone. He develops acid reflux from the prednisone and is started on an acid reducer. He develops a headache from the acid reducer and is started on a migraine medication, and so on and so forth. So has anyone or their loved ones ever experienced this before? I mean, I'm sure it rings familiar for some people. I know I've experienced this as a provider, and it's super hard, right? Sometimes you absolutely need certain medications, and then there are side effects, and how do you deal with that? It's very challenging, but I think we have to be cognizant of this when it's happening. So I've come up with a little list of important medication questions for all providers and people with CF. So when you come into the visit, we should be thinking about, okay, for each medicine, does this medication have an ongoing indication or a reason for prescribing it? You know, what is this drug for? And is that whatever that reason is, that actually still occurring? For indications needing multiple medications, can the drugs be consolidated? So if you're on 2 medications for blood pressure, could we try one medication at a higher dose? For every medication, is this causing any side effects? So we'll just sort of be cognizant of any potential side effects for each person. And if so, are the benefits worth the side effects, and could a lower dose or duration be used? And then finally, if a person comes in with a symptom, we can kind of flip that question and say, okay, can the symptom be explained by a medication? And this is sort of the 4 kind of rules, I think, for everybody to think about as we go through our medication list. And then we should also be knowledgeable and cognizant of the fact that with improved health, we may have opportunities to simplify some treatments like antibiotics or acid reducers, inhaled steroids, and so on. Okay, so this is a lot. We have a lot of new things to think about. How do we put it all together? Well, I think our model of care has started to change and will certainly continue to evolve in the coming years. These were 2 recent CF Foundation position papers that were recently published. And I put a link here, but you can also just go to the CF Foundation website and kind of search for it. And these tackle some important issues, including the frequency and types of visits that we should be kind of thinking about in the modern era. How frequently should we get tests and screening? How can we collaborate and work with other specialists outside of the CF team? And then primary care involvement. So let me talk about primary care involvement for a minute. So primary care could certainly help with many of these kind of new or non-classic conditions, but it's always been a bit of a challenge, right? Studies show that up to 60% of people with CF do not have a primary care provider. PCPs may lack experience or comfort with CF, or they may feel that they don't have a defined role, or feel that the CF team can help more than they can. So it's tough for primary care providers for a very sort of specialized kind of rare disease like CF from their perspective. And from the patient perspective, people with CF may prefer just seeing only their CF team. I mean, they're used to seeing their CF team. They know the providers, they have familiarity and comfort. They may already be seeing too many providers, so why add another into the mix? And they may not trust their PCP's knowledge. So this has been actually documented in the literature that many times CF patients may feel like they're an expert in their care because they've been managing things for years, and they know better than anybody really. And then, in comparison to a PCP who may not have any other patients with CF, it's hard to sort of form that trusting relationship. So these are some of the barriers that have always been present for primary care involvement. Could be an opportunity for improvement, though. I mean, when you think about primary care, it may allow people with CF to get optimal care on things like blood pressure or cholesterol or cancer screening and so on and so forth. And we're doing a QI project in our program here. It's kind of attached to the other one that I mentioned. And our goal is to kind of optimize care of some of these new issues or non-CF related issues, especially in people over the age of 40. And we're working to increase the percentage of adults who have a trusted PCP. And what we've done is we've contacted a few PCPs in the community and tried to get some of these folks to be our lead PCPs to sort of try to take some of our population and kind of help with specialty care. And we've looked at the percentage who have a PCP in our program by age, and this is 2018 are the blue lines and 2024 in the orange line. So you can see that we've seen an uptick since 2018, which is great, and we're trying to work on this. Okay, so in conclusion, the future is bright for people with CF. I think with people living longer, we'll need to work as a community to better understand and manage some of the new issues that may arise, as well as the old issues that may start to look different. The new model of care is likely going to include collaboration with providers in the community, including PCPs. And I would just say that knowledge is power. So, having this knowledge, you can take this to your teams and say, here are the issues that we should probably be thinking more about, because not all teams will necessarily be have adapted to this new model yet. All right, and thanks. And this is a little code. If you have a couple minutes and you want to leave any comments, feel free to do so. Thanks. I think I went a couple minutes over. Sorry, Christy.
No worries. And I forgot to take myself off mute. So I was just talking to no one. Thank you so much. Appreciate it. We do have one question in the chat. So it says, now even more attention to family history of colon cancer and coronary disease is booming number of adults with CF. Are each of these being tracked, or can you see them in the CF registry?
Yeah, that's a great question. I think they're not in the registry. Family history, and the other one that you said was what was the other one, Christy?
Okay, coronary disease.
Coronary, yeah, family history, colon cancer. Yeah, neither are in the registry, but I think as providers, we're starting to kind of ask these questions. And if you're a patient and you do have a history of these issues, please let your teams know, because I've had individuals who are maybe not quite 40 years of age, maybe they're 35, but they've had an extensive family history of colon cancer. I've definitely tried to get those people a colonoscopy earlier than age 40. So they're not necessarily going to be firm rules. If there's a reason to get a colonoscopy or start thinking about coronary disease earlier because of family history, I think we as care teams should be able to make that happen.
Great. I loved your point of, it's hard to get a primary care physician or think that you need one when you're going to the CF doc all the time, but
it is,
are experts in everything. So that was really eye-opening for me.
Yeah, and it's hard to find primary care physicians. Honestly, they're out in the community. There aren't, they often don't have a ton of continuity. That they often. I hear from my patients often that I had a primary care physician, but then they left, and now a new person took over, and now there's a long wait, and these are real barriers, and it's nobody's fault. It's just part of the times, I think.
Oh, good to be aware of. Well, thank you so much for your time. Appreciate it. We will move on to our next speaker. Just a check in on agenda. So we have heard from 3 of our main speakers so far. We've got 2 more coming up, and then we'll have that optional time to stay on and connect. Everyone can come on camera, kind of share and have that community time. So I will go ahead and introduce our next speaker. We have Christina Mertz. She is a social worker at Providence Spokane, and she will be talking about Partnership Enhancement Program, sharing what matters with the care team. So Christina, take it away.
Thanks, Christy. Let me pull up my presentation. Is that looking?
Yeah, the PowerPoint looks great. We lost your camera, which is not a big deal, but just want to make you aware.
There we go. Okay, let me just see. It's okay. So I'm Christina. I am the clinical social worker from the Providence Spokane Clinic. I serve both our pediatric and our adult patients. And I am appreciative of the opportunity to be here with everyone and be present and kind of share my program with you all. So we are going, here's our agenda for the day. I'm going to provide a brief overview of the history of the Partnership Enhancement Program, as well as some of the skills that we will learn, preparing for your visit. So these are the skills that we'll go through today: preparing for your visit, sharing your perspective, and understanding before you go. And then we'll have a little bit of an opportunity for some takeaways. So this is an overview of what the history of the Partnership Enhancement Program is. I'm going to take a brief second, though, to pull up my slides on my phone because I'm not able to see it here. So don't mind giving me 2 seconds to pull up my PowerPoint. So people with CF, families, and oh my goodness, I'm so sorry. My computer is like freaking out. Let's see. I'm using one of our work computers.
Do you want me to share your slides? Would that be helpful?
Let me try one more thing. I was having some internet issues, but if you want to, that might be helpful.
Okay. See how this looks. Are you seeing the slides, or are you not seeing the right thing?
No, that looks good.
Okay.
Yeah, sorry about that.
No worries.
Technology is not always my friend. If you want to go to the next slide. Perfect. The road to PEP, people with CF families and their care teams had indicated that there was a need for better conversations around physical, mental, and emotional health, social and economic challenges, preparing to transition to from pediatric care to adult care, and then sustaining daily CF treatments. So the Cystic Fibrosis Foundation had conducted research and learned people with CF and their families had wanted to have these improved conversations. And this illustration shows that what it can feel like when we're talking past one another instead of connecting on issues. So we may be discussing different perspectives. And the goal when we meet with you as our patients and our families and us as your care team is that we want to mutually develop a plan together. Next slide. So the Partnership Enhancement Program teaches relationship-centered communication for CF care teams. It emphasizes the techniques to keep in two-way information sharing rather than having one-sided conversations. It was developed in partnership with the Academy of Communication in Healthcare, and it's an evidence-based communication training. It's been extensively tested within the CF community. And the training is delivered to the CF care teams by a certified facilitator, either in an in-person workshop or by Zoom. The facilitators are usually CF clinicians from care centers across the United States, but some of the facilitators are actually also parents of people with CF. The Providence Spokane team actually had the opportunity to take this training last year, and we had both our pediatric and our adult care team, as well as one of our adult patients attend the training for us. And it was a really, really great opportunity that we had. And so I'm excited that the PEP team through the CF Foundation had created this. They kind of flipped the script to be able to provide this to patients. So you get to learn some of the same skills. And fun fact is this is the second Ed Day that they're doing this or that they're able to have this teaching. So I'm excited that we get to do that together. Next slide. So relationship-centered communication leads to better outcomes. The evidence shows that when we use relationship-centered communication, our conversation is enriched and it leads to these better outcomes. So that could be better health outcomes, possibly for the patient, maybe in regards to pain, management of diabetes or high blood pressure, as well as outcomes for physician or care team satisfaction that might lead to less burnout, and also institutional patient satisfaction scores. So people maybe are more likely to recommend that care team to friends or family members. Next slide. So PEP offers tangible relationship-centered communication skills that emphasize respect and openness to understand another perspective. So on the left is what we as your care team may see when we're looking in your medical record chart. It's just kind of a simplified list of medications. But on the right is what maybe the person or the family member of a person with CF sees. And everything highlighted in yellow is actually directly related to their CF care that they accomplish or complete during the day. And this schedule was actually shared by a person with CF, and their care team was surprised to see just how much time during the day is spent directly related to their CF care. And this helped the team understand what the impact was of the treatment plan and set the stage for co-production of care. And the new perspective that this patient shared by sharing their day-to-day schedule led to new conversations. Next slide. So we'll be talking a little bit about perspective taking. So this image helps us think about perspectives and how they may impact our conversations. So the image on the left shows a multitude of colors that highlight all the things that shape a person's perspective. That could be events, stress, history, culture, and other things, and how they're interacting with the world on that day. The middle image highlights the reason for the visit. In the case that we're talking about today, that would be going to your CF Care Center. And then the image on the right highlights what we as your care team and as your clinicians tend to focus in on that can overshadow all the other things that shape and define an individual's perspective, as well as influence their decision-making and have an impact on care. So if we don't take the moment to see the full spectrum of someone and all the things that shape their perspective and experiences, my view may impact the outcome of our conversation. Next slide. I think I added a slide, but we'll move on to the next one. Yeah, so PEP skills for clinicians. So this is what we are taught when we were able to take the PEP training last year. It is made up of 3 skill sets. And the skills are taught in that all-day training that I had mentioned earlier. So the first skill set is establishing trust, and that includes addressing what is most important to people with CF and their families. And then the next one is creating open dialogue. So we want to gain a greater understanding about our patients' perspectives, their ideas, their values, their preferences, and their emotions. And then the last goal is setting goals by partnering, or the last skill is setting goals by partnering. So we want to engage in stronger collaboration to share information, create, and confirm the next steps. Next slide. So this is what the PEP team did to flip the script to be able to have this available for patients. And it's kind of focusing on self-advocacy tools. So the first skill is telling us what matters to you. So we want to prepare a list. You could prepare a list of questions or concerns to share with the team. The second skill is sharing your perspective and emotions. So sharing your expectations, your preferences, ideas, and values, as well as naming your emotions and feelings associated with managing your cystic fibrosis. And then the last skill is creating and confirming a shared care plan. There should be one more box that pops up. Yeah, that's so that could be ensuring understanding and agreement on next steps of action. And that kind of goes with what Dr. Kapnatic had just talked about with like medication questions. And so I think that that was a really good tie-in from the last presentation. Next slide. So this is an example of pre-visit planning used at the Johns Hopkins Center, as well as what we use at the Providence CF Care Center. So hopefully you hear us asking about what's important to you early on in the visit. This is a great tool to use if your care center doesn't use this, so that you have the opportunity to also set your agenda before the care team starts coming in. Next slide. So we can just take a quick moment to just kind of reflect on what are some of the potential benefits of setting your agenda before clinic. Some examples could be maybe coming to clinic can be nerve-wracking. The clinical care team may have different things in mind. Time may be limited. Maybe you have to scoot out early to go pick up the kids from school, or there's always a possibility that certain providers may not be available. So if you had maybe dietitian related questions, but they aren't available at that time, you could let the team know, and then your dietitian could follow up with you after the visit. So these are just some other examples of prompts for setting your agenda. That might be financial concerns or concerns about lung function health. That could be related to sexual and reproductive health, pain you may be experiencing, mental health concerns, as well as maybe wondering if you could have the opportunity to network with other patients with CF. Next slide. Okay, so if the clinic team or the care team member does not ask what you would like to discuss during the visit, as part of your self-advocacy tools that we're learning about today, here are some phrases for you to make sure that your needs are being met during the visit. It's a good idea to maybe aim to share your list of concerns early on in the visit and making sure your needs are met. It also helps us as your care team plan accordingly. So for example, the social worker may not have been planning to see you today, but you'd really like help selecting insurance at your new job. So you could let one of the other care team members know. And then, that way the social worker can adjust maybe their schedule so that they'd be able to get the chance to see you and have that discussion with you. So these are just some examples, like I mentioned, and then there is also a handout that Christy will send out after the Ed Day today that has some other examples so that you have some prompts that you could utilize too. Next slide. Okay, so we're gonna move on to the next skill set, which is sharing your perspective and your emotions. So this is all about sharing your story. Often people will share their symptom story that could be related to the cough, their appetite, maybe their exercise tolerance. But we also want to know about the personal and emotional story because it is important to us. So how does this change in your treatments affect your day-to-day activities? How is the financial burden of copays making you feel emotional or stressed out for other financial planning that you may be doing? So what a good idea, or if you're a visual learner, maybe it's imagining a table between you and your care team and encouraging you to put all of your stories out on the table. Next slide. So we'll just take another moment to just reflect on why sharing your personal and emotional stories with your care team may help us move into deeper conversations during your clinic visit. One example that I could give is that if we had a patient who, the team wanted to add a twice daily medication, but that person with CF is already overwhelmed, it's important with that person with CF to share with the team that, hey, I recently moved to a new job, the kids are in a new school, and life is just too chaotic right now. I really don't think I can take on one more change at this time. And so when we as your care team have a better understanding of the big picture beyond just what that yellow dot of CF was, from that perspective, taking slides, a few slides back, we are better able to work with you and come up with a plan that will better fit into your day. Next slide. If you want to hit one more time. There we go. So a few things to think about when sharing your personal and emotional story, and maybe in terms of the impact this may have on your day-to-day activities. So there are a lot of things going on in my life right now that will make finding time for extra treatments to be a challenge. Can we talk about some of the risks and benefits of what you recommend to help me make an informed decision? Next slide. And then one more time. Yeah. We also want to invite you to share your ideas. So the last time I was sick, I was treated with XYZ medication, and it gave me some not so great side effects. Can we try a different medication this time? Next slide. Yep. In terms of expectations, that could be, I haven't been doing all of my medications, or I've been starting to think about getting a job after college. I'd like to talk with someone today about how to discuss CF with potential employers. And then the last thing to consider would be the emotional impact. So Joey has been quite anxious about blood work. Can we do that first before talking about anything else? Awesome. So this leads into the last skill. And I encourage everyone, I have a very long statement and I want you to try and absorb as much of it as possible without being able to see what I'm going to be saying. So there's a lot that goes into getting ready for college. The first thing you need to do is make sure you apply for all of the CF scholarships. You can find information about those on cff.org. The next thing you'll need to do is meet with the Office for Students with Disabilities to see what they need from the center. It may be a form we have to complete, or it might be a letter. Once you do that, give me a call and let me know, and I will help make sure they get what they need from us. Also, you need to think about housing and if you need a private room or would be able to share a room with a roommate. For this issue, you will need to meet with the housing department at the university. And it's really important not to forget your meal plan and discussing with the dietitian about how best to get your calories from the options offered. Do you have any questions? Next slide. So just to reflect, what do you remember from what I just said? Go to the next one. So that was the list of everything I just said. And what I did was that I just kind of threw everything at you and expected you to just download all the information. We talked about housing, meal plan, disability office. That was a lot just for someone to absorb all at once. And when we did the PEP training for our center, this was something that, I noticed, especially just as a social worker, I might have the tendency to do because I have a short amount of time and I want to make sure that everyone, you get all the information that you need. But what we really want to do, both as your care team and then for you as our patients, is if you go to the next slide, we want to do this skill called chunking and checking. So if you think about it as a pineapple, you don't just eat a pineapple whole. What you do is that you chunk it up. And so next slide. This gives an example of how we can break up that social work dialogue that was a couple of slides back and chunk and check it. So I can say, it's so exciting that you got accepted into the university. What plans have you made so far? And then the patient might respond back, I know I want to live on campus and that I will need to make arrangements for if I need to be hospitalized, but I haven't really done anything yet. I would use a reflecting and responding skill. It sounds like you were off to a great start and that you realize there are a lot of steps to make sure you have a good experience. I can use a telling skill and say one of your most important resources on campus will be the Office for Students with Disabilities, and it'll be important to schedule an appointment with them fairly soon. And then I'll use an asking or an open-ended question to see what, if anything, do you know about the Office for Students with Disabilities? The patient could respond, well, I don't really know anything about it, or if that even existed. I could use the reflect response skill to say, thanks for sharing that. That's why I'm here to help. And then the telling school to provide the education on that the Office with Students with Disabilities has a lot of great resources. We're going to work with you on this and make sure you get the information you need. Let's go look up their number now. Next slide. So what are some things that you can say if you feel like information was downloaded on you? I know, we are all kind of guilty of that. So the next slide has some ensuring and understanding next steps. So these are some questions that you could ask. And I also have a PDF that Christy will share out too that has some examples of these. And some of them are similar to the previous presentation too. So like I said, that was a great segue. So that could be, would you mind if I recap what we talked about today to make sure I'm understanding everything correctly? Or asking if you're getting a new medication or different change to your care plan, why is this change being made? And then another good one that I really like is, recapping the appointment and saying, hey, we agreed that I'll continue taking A, B, and stop C, and you'll call me in 2 weeks to check in. Did I understand all of that correctly? Next slide. So here is just a recap of what we covered today. So telling us what matters to you, that could be sharing your perspective on expectations, preferences, ideas, and values. Preparing a list of questions, concerns to be able to tell us what's important for your visit today. And then before ending any conversation or encounter with a care team member, ensuring understanding and agreement with the clinical team on your next steps of action. And then next slide has these are some of the handouts. So you'll get those sent to you. It's really great to be able to print them or just kind of review them before you have your routine appointments. And then if there is time for any questions or feedback, I'm available now or afterwards too. And thank you, Christy, for sharing and helping with my technological difficulties.
You bet, no problem. Thank you so much. I know, Christina, you had mentioned too, putting your email in the chat if anyone had questions afterwards. And again, I will do, I'll send out post-call some of those resources she talked about, but so great. I know a lot of people in this meeting are very familiar with long clinic visit days, and so good to be prepared for those. So thank you. And let me see if I'm popping up the chat if any questions are coming in there. Okay, looks so far not questions, just great. Kudos for you. So let's go ahead and move on. We're almost back on track to our agenda. Yay, thank you. Our next speaker is Drew Yancey. He is a pharmacist at Seattle Children's, and he will be talking about CFTR modulators. Take it away.
Yeah, thank you. I'm excited to talk about things that I enjoy talking about, and that's drugs. I love talking about drugs. So look forward to sharing some information, maybe something new, something reinforce something you already know. I'm Drew Yancey. I am a pharmacist at our Seattle Children's Cystic Fibrosis Center. For those that know me, sometimes I like to come into patient rooms and call myself the drug dealer. So a little bit about me is I have a new dog in the house that may bark during the presentation, so I apologize in advance if that causes any disruptions. And my email address is here. So feel free after the presentation to shoot me an email. I enjoy questions and fielding questions. So perfect. Topics that we will talk about today. I want to talk about the CFTR protein. Maybe many people know and its function. What are modulators and who are eligible? Benefits experienced with modulators, side effects of modulators, and then, I want to know what your questions and concerns are as well. And I love jokes and puns, as you can see by my title, Don't Sweat the Details. And then I love little comics here. So hopefully this doesn't happen, but maybe as this presentation goes on, I might put you to sleep here. So I know it's been probably a long day already, but feel free, jump in, come off mute if you got questions in the moment, or save them towards the end for Q&A. All right, so acronyms and terms used. When I first got into medicine, we love our terms and acronyms, and many times they get thrown around and nobody really knows what that acronym is. So these are terms that I might use either verbally or on the slides, but CFTR refers to the protein, cystic fibrosis transmembrane conductase regulator. Trikafta, sometimes we call it ETI. And the reason why we do that is it's called elexacaftor, tezacaftor, ivacaftor. The newest modulator that just got released is called Alyftrek. And sometimes I like to call it VTD. And that's because it's vanzacaftor, tezacaftor, deutivacaftor. CFTR modulators. And so those are the medications that modulate that protein. And then another acronym that people use is people with CF. All right. So a big part of CFTR and what CFTR modulators do, it kind of is a small molecule that's getting into the molecular level here. So I thought on the cff.org website, this was a great representation of what's going on in the cell. And I think this is especially important as we think about genetic therapies that are coming out in the future. So I think this is analogous to like cooking, right? You have your recipe book, and that's the DNA, right? That's where all the recipes and it encodes for everything that you need to make a dish, or in this case, the CFTR protein. And so the DNA is read, and essentially what is made is mRNA. And stop me if I get nerd alert here, but the mRNA is read and essentially by a ribosome. And as the mRNA is read and the ribosome is reading it like a recipe, you're reading your recipe, you're putting in all your ingredients, essentially, you're going to get this protein here, the CFTR protein. And then essentially that CFTR protein in the middle of the cell eventually gets shuttled to essentially the cell surface where chloride can be released outside of the cell, essentially. So this is kind of the process is what's going on in the body is the DNA is read, protein is made from that DNA, and that protein is making it to the cell surface, essentially. And where is CFTR? So CFTR is everywhere, and this might be information you already know, but it is all over. So I typically think about, places that secrete things. So the bones, the intestines, the liver, the gallbladder, the sinuses, lungs, kind of all over the body, reproductive as well. And so all of these locations are also going to be impacted by CFTR protein and modulators. So how do they work? So this slide kind of represents a little bit, again, what's going on in the cell as well. So CFTR modulators are typically made of correctors and potentiators. The other thing that's currently under development in the pipeline is amplifiers as well. So when we think about ETI or Trikafta, it is made up of two correctors, your elexacaftor and tezacaftor, or we have and so that helps to shape the cell. So going back to originally our discussion about how CFTR is made. So essentially when the protein is made, these correctors help to shape the protein into the correct. So again, these modulators are small chemicals that are binding to the protein and help correct the shape. So instead of maybe having a P-shaped protein. Now you have it corrected into the correct orientation, and that's what the correctors do. And then potentiators like ivacaftor, again, that's why it's ETI, the I in ivacaftor. Essentially, it helps it at the cell surface to make sure that protein opens and closes. And then the amplifiers, which actually there are not any FDA approved amplifiers at this time, but currently in development, they are going to help essentially amplify or make more protein. So modulator eligibility. So this is a point that I always like to point out, and that about 90% or so of mutations that we know about are CFTR are modulator eligible. I do always like to point out that unfortunately, minority races and ethnicities are less likely to be eligible. So I think this is a big diversity and equity point that I always point out, is that it tends to be minority races and ethnicities that are less likely to be eligible for CFTR modulators. And that goes back to some of the function essentially of the CFTR. So CFTR, the modulators help to correct the protein, but in some of the mutations, unfortunately, those 10%, typically 10% of people that are ineligible, the modulators can't work because when the DNA is read, there is actually no protein made at all. So you don't have a protein that the modulator can bind to and correct into the correct orientation. And so about 10% of people or so just don't make any protein, and therefore these medications like Trikafta are ineffective. And something I like to point out, something to talk about your care team, if you are ineligible or uncertain, is consider therapying. So this is where essentially talk to your care team, but essentially where your own cells are sent to see if your own cells respond to Trikafta in a petri dish, essentially. So those are kind of sent off and seen if you actually, even though it's not approved for you to use, and this is likely because most of the time they've never done studies on your mutation. And so therefore, sometimes you can send nasal cells to be tested and see if you actually respond to the medication. All right, so let's look at the benefits. And again, this might be a repeat of things that you already know, but kind of reinforce that lung function. So when we think about modulators, we tend to think about ones that are highly effective CFTR modulators. And when people talk about highly effective CFTR modulators, we're typically talking about ivacaftor, which brand name is Kalydeco, ETI Trikafta, or the newest medication, the Liftrec vanzacaftor. And so what we saw in most of the trials is that lung function improved by 10 to 12%. Sweat chloride, for especially those patients that were F508del, on average, the sweat chloride reduced by 50 to 60, and in some patients, 70-point reduction. So we had a dramatic decrease in your sweat chloride. Most patients gained weight. They also had a decrease in exacerbation. So I've been a member of the care team at Seattle Children's for only about 3 years. So since Trikafta has come out, and before I've heard that it was commonly to have many patients kind of admitted, unfortunately, for exacerbations, but it is less common. And currently at our hospital now, we don't have any patients that are admitted for exacerbations currently. We have a decrease in lung transplants. Improvement in GI symptoms, decreases in sinus symptoms, and then what was talked about earlier is there's been an increase in fertility in women, so an increase in pregnancies. All right, so let's talk about CFTR modulators and what is currently available. I put in orange the highly effective modulators, so this is kind of organized in chronological time here. Kalydeco was our first, or ivacaftor was our first CFTR modulator, came out in 2012, and it's typically reserved for those gating mutations. So as we talked about earlier, ivacaftor works at the cell surface to help the gate open and close. currently approved down to 1 month of age. So we can, if you have an appropriate mutation, we can actually start Kalydeco at 1 month of age for those patients that are eligible. Next that came out was Orkambi, or Lumacaftor, Ivacaftor, and this is currently approved down to 1 year of age. Next that came in the sequence was Symdeko, currently approved down to 6. And then, of course, in 2019, Trikafta was approved initially at age 12 and older, and now is approved down to 2 years and older. And then the newest modulator is Alyftrek that was just approved on December 20th. So that would be Vanzacaftor, Tezacaftor, Ivacaftor. And that is currently approved for patients 6 and older, was the newest approval. So CFTR modulators are super, as you are probably aware, extremely expensive. And so this is the data actually I just pulled last week from our hospital. So when our hospital needs to order this medication, this is kind of the cost that we actually pay to purchase it. So it's, as you can see, most of the modulators cost about $27,000 or so a month, essentially in cost. With the newest one being the most expensive at about $2,000 more a month. They're extremely expensive, and this has been kind of the biggest pain point for many patients, many insurances, and a lot of people in the industry, as well as, you know, them not being available in most countries throughout the world as well. With that in mind, being a pharmacist, this is my goal, is to always make things as cheap as possible for patients. So these are just kind of a list of places I tend to refer patients to try to get as much free money as you can. First stop is always just talking to CF Foundation Compass and seeing what's available. They may have more information than I currently know about. The modulators are made by a company called Vertex, and they have a copay assistance program that offers up to $20,000 annually in support to patients. Another organization that we commonly use is called Healthwell Foundation. So this is a grant essentially that will give up to $15,000 a year to help pay for not only modulators, but other medications as well. And in this, it's actually currently open. So Healthwell Foundation sometimes opens and closes their grants, but currently is open for applications to apply for the $15,000 annually. Other foundations, the Patient Advocate Foundation, as well as the Assistance Fund as well. All right, as probably reviewed earlier in this Education Day last month on December 20th, there's a big announcement from the FDA and the CF Foundation about Trikafta and Alyftrek approval. So on December 20th, Trikafta, one of the things that happened is Trikafta got approved for 94 additional mutations. So actually that helped many patients that were previously ineligible for modulators. Now they have access, or essentially more access to modulators now. One of the other things that happened during the approval process is they actually added a boxed warning on Trikafta for essentially more frequent LFT monitoring, so liver function test monitoring. I'll get into a little bit later as well. Additionally, what was approved on the 20th that many people might be excited about is the new modulator, Alyftrek. And this was approved, as I mentioned earlier, for 6 and older. The other thing, so people that are eligible for Alyftrek would be anyone eligible for Trikafta. So anybody that's currently on Trikafta basically would be eligible for Alyftrek. In addition, Alyftrek was also approved for 31 additional mutations that are not Trikafta responsive. So there are more, it is more at the more eligibility essentially. So there are 31 more mutations that are eligible for Alyftrek that aren't available for any other modulators. So most of this information that I'm going to talk about is something that was from those clinical trials. So essentially when Alyftrek was approved by the FDA, they basically compared Alyftrek to Trikafta. That's the data that they used to get the approval from the FDA. And so most of the information I'll talk about here is from those trials. And so what they saw in these clinical trials that compared Trikafta and Alyftrek is that Alyftrek basically was essentially very similar in lung function. And that was for 12 and older. Essentially, Alyftrek showed a 0.2% improvement in lung function. Sweat chloride, what we noticed with Alyftrek is that sweat chloride was reduced a little bit further with Alyftrek. 2.8 to 8.6 points. And that kind of depends upon what mutation you had and how it responded. And so I guess this slightly favors Alyftrek, although this is something where I want to point out that you talk to your clinical care team about if this is important. Sweat chlorides have their useful information, but it may not be the end all be all for your care, essentially. And convenience. This tends to be Alyftrek. Well, let me go back. Trikafta is an extremely confusing tablet scheme. You got this weird morning tablet, 2 tablets, and then you have tablets at night that are completely different, and just so it's a completely nightmare of different drugs taken at different times of the day, essentially. And what's convenient about Alyftrek is actually a once-a-day medication where all tablets have the exact same drug amount in it, essentially. And depending upon your age and weights, it's either going to be 2 tablets or 3 tablets just taken once a day. So that is super convenient. So this is a picture of essentially how it's going to look as well. So it's going to be packaged very similar to a lot of the other modulators as well. For those 12 and older or weighing greater than 40 kilos, it's going to be 2 of these lavender colored tablets. And then for patients that are 6 to 11 that are under 40 kilos, that is going to be 3 P-shaped tablets just taken once a day with fat-containing food. So we talked about a little bit of benefits. So what are the side effects with these medications? And so this, I want to caution that this is kind of information, again, taken from those clinical trials. And as I put here, it's difficult to say with certainty that some of the things I'm about to say are true, actually, or what's true here. Liver injury, what they noticed in the clinical trials is that 1.2% of patients had high LFTs. And when I say high LFTs, they were 5 times greater than normal versus Alyftrek, they had about 2.5%. But again, this may favor Trikafta, but again, it's difficult to say because this was not certainly an apples to apples comparison, the way they ran this clinical trial. So this may not be exactly the full story. Mental health, as it's kind of known in the community, is that some patients had mental health side effects with Trikafta. Again, I put a question mark here because this is something that it's been confusing in the data, as well as the FDA and Vertex have not quite acknowledged this. Alyftrek, this was not, again, in the clinical trial, they had no reported side effects. But what we know, again, with Trikafta was that also wasn't reported in the clinical trials as well. And so there's no information really to consider of knowing if Alyftrek will be any better for mental health. What I put here is consider retrial. So there will be a trial called retrial, and that's for patients that essentially had to stop Trikafta because of mental health side effects or liver injury side effects. And so for patients that want to start Alyftrek, potentially because that were stopped Trikafta because of these side effects, liver and mental health, that this trial will actually kind of be monitoring or at least give information to better understand if Alyftrek will have mental health side effects or an increased liver injury as well. Things from the clinical trial, again, for Alyftrek is there is slightly more frequent rashes, sinus congestion, and headaches. But again, it's hard to know if this is going to be actually a true story that we see in practice as well. So as I alluded to earlier, Trikafta and Alyftrek both had new updates with monitoring liver function. So for new patients that are going to start Trikafta or Alyftrek, the recommendation is for every month. So every month for 6 months to get liver function tests. So this is just a simple blood test that sometimes we can do through a finger stick. But when you first start the medication, we want to make sure it's not irritating your liver. So every month for 6 months. And then after completing that, we'll go every 3 months for a year, and then annually thereafter. Pediatric patients will continue with Alyftrek to recommend eye exams for cataracts. The drug interaction profile is essentially very similar or the same between Alyftrek and Trikafta. So always talk to your care team about newly prescribed medications and if they will interact with your modulator if you are taking a modulator. Continue, and a big counseling point is to always take with fat-containing food. What I noticed when I peeled apart the package insert, again, big nerd alert here, I read the package insert, is that 6 times more vanzacaftor was absorbed when it was taken with a fat-containing meal. And with Trikafta, it's about 2 to 4 times more drug was absorbed when you take it with a fat-containing food. Something that may not be discussed a lot that I nerd out on is avoiding bergamot oil. So what is that? So that is like when people, like when you see those drug ads or whatnot, avoid taking with grapefruit juice, blah, 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 blah. And so essentially grapefruits and actually Earl Grey tea and Seville oranges contain a chemical called bergamot oil, and that will actually interact with some drugs that are processed through the liver. So again, with these modulators, we want to avoid bergamot oil. And then many people don't believe it or don't know to think about it, is always discuss herbal and supplements with your team as well. So something like St. John's wort, again, you think it's just an over-the-counter herbal, actually will have a drug interaction with your modulators. And then I also, always talk about cannabis use with your care team as well. So this is just my opinion on Alyftrek. So again, I always encourage you to discuss this with your care team as well. We only have experience, so I have 5 years of experience, essentially, or 4 or 5 years of experience with Trikafta that I can give patients information about. But I don't quite have that wealth of information on Alyftrek, and that we only have experience from the clinical trial. I think it's an amazing option for patients that are now eligible for a modulator. Those 31 mutations that are approved for only Alyftrek, and then those 94 new mutations that were approved as well. It's a great option. And then again, going back to talking to your care team, patients that did not tolerate other modulators, right? I had to stop my Trikafta because I had a significant amount of anxiety. It might be, we don't know if Alyftrek will cause that same level of information or same level of anxiety. And it might be something that I'm a big proponent upon, is enrolling in clinical trials. So we know we have a well-controlled documentation of side effects, essentially. So retrial again for those that didn't tolerate modulators previously. Patients that did not seem to have a dramatic effect with Trikafta, right? We didn't gain a lot of weight. We didn't have a dramatic impact on lung function and things like that. And then, my teenage population that I see, I even struggle with myself. Twice a day medication doesn't sound that hard, but when you get into practice, twice a day is actually difficult. That sometimes you missed one of those throughout the day. So again, if you struggle with remembering to take medication, this once a day option is very attractive. And then I just want to give a thank you to the whole CF community that have nurtured me, and I really appreciate given the opportunity to chat just about my opinions and what I know about drugs, something that I know a lot about. Any questions?
Thank you, Drew. Yes, we got a few questions here. One I think should be a quick yes or no, I guess. Can you clarify, is Trikafta eligible at 2 years old, but Alyftrek still learning. Alyftrek, not
A
until.
lift, yeah, like the ride sharing, a lift,
know, I
lift,
know.
yeah.
So Trikafta, you could start at 2, and Alyftrek, you could start at 6. Is that right?
Currently, as is. If you log on to cff.org and look at the clinical trials, there actually is an open clinical trial to study Alyftrek from 2 to 5. But as of today, yes, Trikafta at age 2 and Alyftrek at age 6.
Great. Next, I think you touched on this a little bit, but what's the impact of sweat chloride levels being reduced by a modulator?
Good question. This is again a good discussion to have with your care team. Everybody's response is going to be very variable. And there is still more research and information to know how significant are the clinical impacts of, and when I say clinical impacts, like what does that really mean? Does an 8-point reduction in sweat chloride really mean something for you, essentially, as the patient? And so, again, that's what they use to show its efficacy to the FDA and to get approval. But for you as an individual taking modulators, I think that's a discussion to have kind of with your care team to know if that will actually make a difference for you.
Great. Next, probably hot on everyone's minds, when exactly will patients be prescribed Alyftrek? Do you expect care teams to do this switch automatically?
That is, again, going back to just having that individual discussion with your care team. Essentially, my personal opinion, again, this is my bias and personal opinion, so I'm gonna put that disclaimer on it, is that if you're doing great with Trikafta, I actually, personally, what I would choose for myself is to stay with Trikafta. If I'm doing great with Trikafta, I will probably stay on it. I'm a little bit more reserved and shy about starting a new drug, essentially, with not a lot of knowledge out there on it. So that's my personal bias on that. And if we get more and more information available, then maybe I will adopt it. But again, I think that's a discussion to have with your doctor to know, and everybody's going to have a different opinion. And then going back to this last slide that I had here, everybody just talk to your care team. If you didn't quite have that dramatic effect with Trikafta, or you're struggling with compliance, but again, I think this is a highly individual discussion to have with your doctor.
And I'm assuming she was asking if the care team would switch automatically. I don't think anyone would just switch the prescription without that conversation. Is that right?
Yes, and I think it's also important to point out that when you start this new medication, that actually you're going to have to do liver function tests every month, essentially for 6 months. So I want to point out that if you do switch, that I want you to make sure that you're properly monitored for safety and that it's not irritating your liver or having any other side effects.
Is the liver function test, I bet everyone on here knows this, but is it just a blood test or is it more involved in that?
It is a
Okay.
blood test, yeah. In our center, we actually do it at Seattle Children's. We can do it through a finger stick. Some places don't do that, but we can. So it's a little less invasive with a finger stick.
Great. Also in the chat, we've got your support from Dr. Kopnadik on what your opinion slides. So that's good. We got a +1. And then let's see, does Alyftrek have any interactions with hormonal birth control or interaction with other common drugs?
Birth control, I do not believe so at all, that you will have any interactions with birth control. The only one, the modulator that we know had drug interactions with was Orkambi, essentially. But Alyftrek, I don't expect there to be any difference between that and Trikafta as well. What was the second part of the question?
Oh, just any other interactions. I think kind of when you were talking about even those supplements that you wouldn't think to bring up, but just general.
Yeah, it will have probably the same exact, if you're on Trikafta, it's going to have the same side effect profile to worry about. So again, a common question I get as a pharmacist is, right, oh, I'm on Trikafta and I want to start Paxlovid. Paxlovid's a drug to treat COVID, and we know that has a drug interaction. or things like we use antifungals sometimes in the CF world, and so like voriconazole, antifungals typically have a big drug interaction, but there shouldn't be any difference between Trikafta and Alyftrek on drug interactions. But again, things change. New information comes out, and it always just have that discussion or check in with your care team.
Great. And I think the last question here, we'll see if you have some insight. How long until the modulators are eligible to be made in a generic with hopefully a cheaper cost?
Oh, I think I looked at this week actually, because I was curious myself actually. So, well, I could talk about this forever, but to answer your question directly, I think Trikafta comes off patent in 2032, technically. So we still have a way. And that will be the first one, because Alyftrek's a brand new one, so they get their patent longer, that type of thing. So Trikafta will likely come off patent in 2032.
All right, 7 years. Start counting. Well, this was so helpful. I appreciate you and your time. Dr. Kopnack, did you want to pop off? I saw you put something big in the chat. Anything you wanted to add or share?
No, I tried to, sorry for the run-on sentence there, but
Love
yeah,
it.
I agree with what Drew said. We just had a meeting about this with our providers in our adult clinic, and we're trying to kind of get the process ironed out with the specialty pharmacy. But we were just going to kind of plan on having a talk with every person during their appointments and kind of say, here's this new medication. If you're doing great on Trikafta, you don't mind twice a day dosing, probably fine to just stay on it unless you have a strong preference to switch. And then for people who have struggled with twice a day, or they don't, they get busy in the afternoon, or they've had side effects or just aren't doing great on Trikafta, we may suggest switching. But the adult providers at UW kind of said we'll have a discussion with each person and make a decision based on their preferences and the clinical status.
Great, thank you so much. All right, well, that concludes all of our medical speakers. I'm going to share just a little bit about the CF Foundation, some programs we have coming up. Before I do that, I'm going to put in the chat a link to a survey. Would love to have 100% participation. If possible, just click that link. It's not too many questions. It helps us to improve these types of events, make sure that you guys are still wanting them. They're important to you. So if you could take a minute to take that survey, that would be amazing. And then I will go ahead and share my screen, just again, talk a little bit about some of the stuff the CF Foundation is doing. And then we'll have that time for community connections. So share here. Okay, got my chat there. Okay, so the CF Foundation, I know many of you are very familiar with. We are a national organization. We are headquartered in Bethesda, Maryland, and have chapters all across the country. Today, I want to focus a lot on our programs. These slides have way too many words. Even when I put them together, I said, Christy, no one's reading all that. But I will put links in the chat as well and do a follow-up email so you have all these resources. But these are some of our programs. So Community Voice is a way for people with CF and their family members to share their feedback, their experience, and really give us at the CF Foundation a way to know how to move forward. It kind of shapes what important projects or things that are affecting you. It can be you just fill out surveys. We love a survey, or there are some like focus groups on specific topics. So really great to have the CF community informing our work. CF Peer Connect is a one-on-one connection. So for anyone that is 16 or older, if they have CF or is a parent or some sort of CF connection, we can make those one-on-one connections so that someone who's been through what you're going through can share. We've got Compass, as Drew mentioned. This is a great program run by the CF Foundation. You can either call, email, or go online, do an online request for any issues you might be having with insurance, finance, legal, and other. So great resource to reach out to them. Grampians, I would be remiss if I did not bring up Grampians. We've got our Grampians chair, Dan Vache, here on the call, but this is a program for grand people, but it could be grandparents, people who support the foundation and want to connect with the community. We also have Tomorrow's Leaders, which is for our young professionals who also support our mission and want to connect and develop some professional skills and do some networking. Advocacy is a huge thing that the foundation does. We are trying to get in front of lawmakers to make sure that people have access to drugs, that the government is helping to fund any sort of research. One big thing right now is just antibiotics, getting some funding to encourage people to create new antibiotics, as there's a lot of antibiotic resistance. That's called the Pasture Act. There's a link on the screen here. Again, I'll put in the chat, just so you can sign up for those alerts. And then these are some upcoming events and meetings we have. So some virtual, some in person. These first two, BreatheCon and ResearchCon, are both virtual online conferences for the whole foundation nationwide. BreatheCon is for adults living with CF, a great place to connect with other adults. ResearchCon is really for everyone. So if you have a personal connection, professional connection, you can learn about CF-related science. So again, there's a link there. That'll be in May 6th. And then in person, for those near the Seattle area, Bellevue actually, we will be having an in-person dinner, our Washington, Alaska chapter annual meeting on Tuesday, March 4th. So we'll kind of review how our 2024 year went, honor our top supporters, and then talk about what's coming up in 2025. And we've got a way to RSVP there. And then lastly, on the right side, these are our core fundraising events we do here in the Washington, Alaska chapter. Would love to see many of you out there. Great Strides is our walk program. So we've got 5 different walks coming up this spring. A mini plug, I have to say, next week is registration week. We are working to get 65 teams registered before the end of January, which is Friday. Somehow January is almost here. The end of January is here. So if you are planning to walk with us, we would love to have you sign up. So there's my plug. End of that. We also have a golf tournament. We have a cycle event. We've got a drive-in movie. We have our stair climb and our Breath of Life gala. So those are all the events that we have coming up. And I will stop sharing. And just make sure there wasn't anything in the chat here. Okay, perfect. So that will end our Education Day portion. Again, stay on for this community connection. I'm going to stop recording as well so that we can just chat and not have this part of our whole thing. So there we go.